thank you so much for being here today. We'd like to welcome you to the Senate Committee on Healthcare, and we hope this will be the best part of your day. We're glad you chose. We're glad you chose to be with us today. Let's do a couple of really important things first. We have some pages, and I believe we have all our pages are in this committee today. Bella Antunes, is that right? Bella? Is Bella here? No, Bella? Hello, Bella. Bella's from Asheville, sponsored by Senator Mayfield. Reagan Bembridge. Reagan is from Kitty Hawk, sponsored by Senator Sanderson. We have William Chow. William, glad to have you from Raleigh, sponsored by Senator Chattery. Penelope Goldstein. Penelope, glad to have you from Huntersville, North Carolina, sponsored by Senator Hannig. He's not from Huntersville. How'd that happen? Okay. I think he's from the coast, is he not? Anyway, glad to have you. Chris Hill from Wilson, North Carolina, sponsored by Senator Buck Newton. Abby Jacobs from Lumberton. And I bet you're sponsored by Danny Britt, I would bet. Sarah Penny from Efland, sponsored by Senator Meyer. Glad to have you. Elizabeth Perry from Greenville, North Carolina, sponsored by Senator Smith. And last but not least, Emma Satterfield from Wilson, and she is sponsored by Senator Buck Newton. Welcome, Pages. We hope you are enjoying your week, and if we can help you in any way, let us know. We know you'll learn a lot. Also, would like to recognize our Sergeant of Arms, Tequila Cogdell is here. We have John Enlow, Dwight Green, Rod Fuller, and Dean Gaffiston. So glad to have you guys with us today. Folks, we have one bill that is being considered today, and I'll point out to you, the chair made the decision yesterday that we'll have discussion only. There's a lot of information in this bill, a lot to understand, a lot to digest, and we want to make sure that we had plenty of time to do that and plenty of time for discussion. So it'll be discussed today. There'll be no vote, and then at our next meeting, we will likely put it back on the agenda, perhaps for a vote at that time, but will be no votes today. So I will tell you the PCS has been properly noticed, and without objection is before you, before the committee. And with that said, we have Dr. Reeder, who I think is going to explain the first part of the bill, and then we'll recognize Senator Bergen for the rest. So Representative Reeder, recognize you.
Well, thank you, Chair and members of the committee, and thanks Representative Baker for being here with me. I'm really here to talk about the first part of the bill, which was the original 681, the Interstate Medical Licensure Compact. And the goal of the bill was to help facilitate medical license across state lines. If this was enacted, it would make it easier for physicians to obtain a medical license in North Carolina. And as I'm sure you all know, each state is independently responsible for verifying educational and training requirements, ongoing CME, complaints, and disciplinary issues. And these are the things that the medical board uses to issue a license. With telemedicine and recruiting physicians to North Carolina, if we can reduce the barriers to getting and obtaining a license in North Carolina, that will help improve access for our citizens for medical care. With telemedicine, you actually have to have a license where that patient is sitting. And so if they were in a border state, you actually have to have a license to be able to do telemedicine across state lines. And so those are some of the things that is important. In this bill, it will streamline the application and licensure process, but North Carolina will still retain the ability and the authority to offer a license or not. Just because we enter in this compact, it doesn't mean that the Medical Board of North Carolina loses any of that authority. The Interstate Medical Compact Commission, which started functioning in 2017, so it's been around for a while. It's a non-governmental organization. It collects data about physicians, their licensure, and all of those requirements. There are currently 37 states and 2 municipalities, Guam and Puerto Rico, who are part of this compact. So what other states have found when they join the compact is that they have about a 10% increase in the number of licenses offered in the state. It actually increases fees to the North Carolina Medical Board. As part of the compact, if I, as a physician, want to use this, I have to pay the full price for a North Carolina license, as well as a fee to the medical board. So from the medical board standpoint, financially, it's actually a winner. It allows physicians to work in multiple states. It doesn't change the scope of practice for any physician in North Carolina. North Carolina will still maintain that, the limitations on practice, all the requirements that North Carolina has, they will still maintain that. Physicians are not required to go through the compact. If someone is committed to come to North Carolina, they just want to come here, they can still get the license as they do now. There's a number of criteria that I can go into detail if there's questions about what is required as part of the compact, but in the interest of time, I'll limit that. Overall, this passed unanimously in the House. There is not any opposition. This is a contract, and that's why the language of the bill is so detailed, is that this really creates a contract with the medical board in the compact. And so I'm happy to answer any questions, Representative Baker as well, and ask that you consider supporting this part of the bill.
Thank you, Representative Baker. Do you have anything to add?
Thank you, Mr. Chair. Just appreciate the opportunity to discuss the bill. And I would just highlight the fact that this, in every state, it has increased the number of physicians and therefore access to medical care by at least 10%. In some states, it's been as much as 30%. So again, just a bill that has been very well vetted and could increase access for our patients. Thank you.
Thank you, Representative Baker. We'll pause at this point and take questions, Representative, if you would take questions on your part of it. Members, do you have any questions of the bill sponsor? Anyone? Senator Adcox recognized.
Thank you, Mr. Chair. No question. Actually, I just wanted to say there's been an RN licensure compact in place for like 25 years. It's worked great. There's a model for this out there. I'm in full support of this part of the bill. It makes perfect sense for all the reasons that have been enumerated. Thanks.
Thank you, Senator Woodard.
Yeah, I would just say ditto. Y'all actually heard me say ditto. How about that?
Okay.
So, to Senator Adcox's comments, and I appreciate the work y'all have done on this. I know this is a complicated thing, having worked on this a little bit in my professional career. So thank you all very much. Good piece of legislation.
Any other senator have questions or comments? And we will take questions and comments from the audience. We'll do that after the full presentation, and we'll have all our folks up here to answer those questions. So seeing no more questions from committee members, we recognize Senator Bergen at this time to explain the balance of the bill.
Thank you, Mr. Chairman and committee. It's a pleasure to be here, and I want to talk about the remaining part. Part 2, standards of supervision agreements. Under current law, all PAs and NPs must be supervised by a physician. Most PAs must meet with their supervising physicians once every 6 months. NPs must meet with their supervising physician monthly for the first 6 months of supervision, and then the physician must be continually available after that point. Continually available is not specifically defined. Now, folks, I support the PA bill, House 75. I think that was a great bill. We need to go ahead and move that. So I want to just tell you I do support that. Also under the PCS, physicians must meet with their PA or NP for at least an hour, at least one time per week. Physicians must review 10% or 20 case files monthly. Physicians cannot charge more than $10,000 per year for supervision. Anesthesiologists would be limited to supervising one anesthesiologist assistant, one student anesthesiologist, or one qualified anesthesia provider at the same time. Part 3, full practice authority for experienced nurse practitioners. NPs would be able to perform any medical act without the supervision of a physician if they have been practicing as an NP for at least 3 years and 2,000 hours, not had any professional discipline in the last 5 years. Part 5, surprise billing. The PCS largely mirrors the federal No Surprise Act. Any covered medical procedure at an in-network healthcare facility must be billed at in-network rate, even if it's an out-of-network provider that performs that part. Part 4, and the facility fee part, we do have a little bit of work to do on that. That's why this is for discussion only, and we'll be clarifying some things in there. Part 5, facility fees. Healthcare facilities would not be able to charge a facility fee unless the procedure was performed on the hospital's main campus or at a facility with an emergency department. DHHS must identify services that can be safely and reliably performed in non-hospital settings. No facility fee can be charged for these services. DHHS can audit facilities for compliance and assess a $1,000 penalty for each violation. Illegal facility fees would also be considered unfair and deceptive trade practices subject to triple damages and attorney's fees. I want to thank Dr. Reeder. He and I have talked about a lot of things. He's given me some good advice. All of it I didn't take, Dr. Reeder, but he'll probably talk about that in a minute. But also I want to thank the co-chairs. I want to thank Madison Allagood over there for all of her work on it, and Jason Moran Bates for all his work. And at this time, and let me just say a couple of other things. I talked to a bunch of doctors this morning, and just some things that trouble me about healthcare is, we've got a big need for healthcare workers in every facility. I talked to some guys at Rex this morning. There were 9 people in the emergency room at Rex that were involuntarily committed this morning. And so talked to them about that. And then just talked to them about this bill. I talked to 4 or 5 folks about this bill and their thoughts. I don't think this is the final product we need to end up with. I hope it's a point of discussion. I think I've told everybody I've ever met with in the 6 years I've been up here, I will talk to anybody about anything. I think that's how we get good legislation, because I know it never starts out as good as we all can make it if we work together. And Mr. Chairman, I'll be happy to answer any questions and anything else that we need to do.
Thank you, Senator Bergen. First, we will turn to any questions or comments from committee members. Any senator that would like to speak. Senator Woodard, you're recognized.
Thank you, Mr. Chair. And Senator Bergen, I appreciate your concluding comments there, because I've only seen this for a couple days, and as you might imagine, I have plenty of thoughts about it. And so I guess I'm getting to a question, Mr. Chair, so be patient with me. I guess one of the concerns and one of the areas of conversation, well, let me start with one that's simple. The one anesthetist to one NA is, I understand the safety concern there, but currently I think it's one anesthetist to 4. And I think we need to have some conversation around that. I think this is going to have a chilling effect on surgeries, and particularly elective surgeries. I'm afraid that some surgeries will be delayed. Often an elective surgery, emergency surgery, sure, people are going to get those, but there are some elective surgeries that can be put off for a period of time, and I'm afraid some of them will be put off for too long, and then they become emergencies. So I just need to say I have some concerns about that, and have some real concerns. The facility fee piece also is a little troubling because, and I know you represent rural counties, I have as well, but of course I live 1 mile from one of the state's premier medical centers, and have worked there. The facility fees are always an easy target when we talk about reforms in healthcare. However, they also allow health systems to provide services in rural communities, particularly non-hospital based clinics. And again, I think restricting the facility fees the way this proposed bill does is actually going to limit, and I think maybe even lead to closure of some of those non-hospital based clinics in our rural communities at a time when we need them. And I don't need to tell you this, needs them even more. I'll just say my third concern is around team care. In my career around medical centers, I've watched, especially over the last 15 to 20 years, team-based care has become more and more important, particularly as we face challenges in our workforce. And again, a topic you've worked on. And what concerns me here is that with what you're proposing in this legislation is that we're going to move away from team-based care. PAs will still be required to have more than 4,000 clinical hours and 1,000 hours of supervised experience in their specialty. But nurse practitioners would just have 3 years and 2,000 hours. Then they're going to be given a lot of latitude And it concerns me a little bit about that. This is where I want to have the conversation, because then the NPs, I think, will then have the ability to treat complex cases, cancer, autoimmune, maybe even ALS, outside of the team setting, and could order tests such as PET scans, CAT scans, and other tests without the supervision that we're still going to require PAs, by the way. Rather than ask a series of questions, I just wanted to get those concerns up on the table. I'd love to hear your thoughts about that. But these are the concerns I have with this bill, and I think we need to have a lot more conversation, at least around those three things. Because if there's one thing I know you and I agree on, is we want to provide access to care, particularly in our rural communities and our underserved communities. But beyond that, I have some concerns, and I'd love to hear your thoughts around compromising patient safety and outcomes.
Senator Bergen, you're recognized to respond.
Thank you, Mr. Chair. And Senator, I have those exact same concerns. And that's why this is in the form that it's in. And that's why we're discussing it. Let me just talk about a couple of the things. Anesthesiologists can bill for 4 surgeries that are going on simultaneously. Now, and Dr. Reeder, like I said, he and I had a great conversation, and we talked about it. And what the anesthesiologists say is that we're there for the start of every surgery and the end of every surgery. That's a message that I got. But then in talking to nurse anestheticists and other people, that is not the case, especially in rural areas. So, and I've talked to a number of CEOs of hospitals about what happens in areas, and especially if there's not an anesthesiologist there, and the billing and all that. So, I just think we need to address, because we desperately need more people to do anesthesia. What level we decide on and where we are. I've talked to hospitals that say they're struggling right now to get anesthesiologists and to supervise, and some of these practices where they're independent, they've left hospitals or renegotiated, and so that gets very complicated for people, and it drives up cost. So I think that's something. I haven't been able to get, I hope maybe somebody here has it today, how many physician practices or how many physicians work for hospital. Nationally, it's 70% of all the doctors work for a hospital.
Or a health system.
Or a health system, yes, true. The problem is I can have a practice in Harnett County that is doing what they normally do, and then let's say that they sell to Cape Fear Valley. Nothing's changed at that practice, but then the facility fee can be added and the cost increased 30 to 40%. Nothing changed there, but they're making a lot more money from doing it. Now, a lot of the doctors, and I've been and visited at Mission and a bunch of hospitals across the state, and I talked to them about what happens. I've talked to doctors, I've talked to facilities. I know that Mission has lost a lot of doctors, because I talked to doctors that sold their practice, and not just Mission, it's a bunch of folks. And they tell me that, the sale is, and I'm a salesman, so the sale is, we'll buy your practice, you'll make more money, we'll take off the burden of management and bookkeeping and billing and all that, and then the hook is, 2 months later, you got to see 22 patients a day. So I know, and I know people saying, well, that doesn't happen everywhere, but to the doctors that I've been talking to, they say that it happens. I want that discussion. I want to talk about that. And everyone in here would admit healthcare is too expensive. I've had, since bills come out, I've had numerous people come to my office or call me, and I'll talk about the medical debt in a minute, and talk about they have great insurance. They went to a provider that was in their network. Nobody said a word to them. And one lady has a $3,000 bill right now, and it's somebody that walks these halls. And that's concerning to me. It's concerning for everybody. Now, I've talked to my friends over at Duke, and I know they're concerned about it, and I've heard from them. And but but it's a discussion we need to have. And as far as team care, I think is the best model, because it's just like up here. Every bill we probably run, if it was just up to us and we ran it through and nobody else touched it, it probably wouldn't be as good as it is from going through the committee process. Now, as a business owner, I get real frustrated that we can't move things faster, but I understand what our founding fathers and our state founding fathers all had in mind, is that we need to do this. We need to have discussions. We need to debate. That's why I love the process now, because it makes a better mousetrap. And I think that's what we're trying to get to. But I'm happy to have those discussions. You have the exact same concerns that I have. Mr. Chairman, I'm done.
Thanks, Senator Bergen. Senator Mohammed.
You got a follow-up?
Oh, yeah. Sorry.
Just
Follow up,
and
Senator
I want
Wood.
to keep, and I don't want to dominate this because I think there's a conversation we clearly need to take out of committee and have with plenty of other stakeholders here. And I guess I just want to make sure we continue the conversations with the stakeholders. And I agree with, we should talk about the anesthesiology question, because I think there are some things there that I think ought to be addressed. The 4-to-1, okay, talk about that, but the 1-to-1, I do think will have a chilling effect on that. And as for the facilities fee, I'm just going to say this. Mission's a tough example to use for anybody right now, given all the issues around HCA's managing the mission practices. But even under the HCA regime, using facilities fee and with all the challenges Mission's going through right now, they're still keeping some of those, they've committed to keeping a lot of those rural non-hospital facilities open. And while it increased costs, it's also keeping the door open. And I think that access in these rural communities is critical, and it don't come free or cheap necessarily to keep some of these rural practices open and rural facilities. So where we land on that's, I think, very open. I'm afraid the language you've proposed is a little too tough and is going to lead to some closures. So I suspect we can find somewhere in between. Thank you, Mr. Chairman.
Senator Bergen.
Senator Woodard, I'm always delighted to talk to you.
Senator Mohammed.
Thank you, Mr. Chair. Question for the bill sponsors or staff, but I'll just make a quick comment first and then a question, Mr. Chair. Senator Bergen, I appreciate your efforts. I completely agree with you. The cost of healthcare is way too high. I mean, I see it every day right now where I get clients that don't want to go to the emergency room when they're hurt. They don't want to do certain procedures because they're worried about the cost of care. Nobody should have to deal with pain and suffering just because of the cost of care. So I appreciate your efforts here. My question is with part 2 of the bill, which you mentioned, which talks about nurse practitioners. My bigger concern is that they'd be able to perform any medical act without being supervised by a physician if the following's met: practice under the supervision for 3 years or 2,000 hours. So my question is, because again, trying to bring down the cost of healthcare, I see what you're doing, but my concern is always patient safety at the end of the day. And I want to make sure the most qualified individual, the most experienced individual is readily available to my constituents and the patients in need. So with that being said, how does your bill, or can staff explain, how is that scope of the practice determined for that unsupervised nurse practitioner? Can they do one area of expertise for a number of years and then suddenly now go into another practice area? That is something I feel like is unanswered in your bill, and maybe it is, and maybe that's why I deferred to staff or you. So if you can answer that, thank you.
Thank you, Mr. Chairman. And rather than me explaining that, if I can phone a friend, we happen to have Senator Adcock here that has those designations. She can probably explain it to all of us better than anybody in this room. May I, Mr. Chairman, would you recognize her, please?
Senator Adcock, you are recognized.
Thank you, Mr. Chair. Thank you, Senator Bergen. So what I'd say, Senator Mohammed, is the current statute that we have in rules make it clear that nurse practitioners, and I would add my PA colleagues, many of whom are in the room today, that our scope of practice is defined by our education, certification, and experience. So we're not practicing outside what we're prepared to do. And currently, when we need consultation, collaboration, we reach out to whatever other healthcare provider we need to do that with, whether that's a physician or a nutritionist, physical therapist, or whomever. And so that's part of ethical good practice. And while I'm at it, I'll add that everybody wants team-based care. And I would say that doesn't imply that anybody in that team needs supervision. They all bring their own skills and expertise to the table and work together. Neither does team-based care imply they're all in the same location, because often you're in one practice and the person that is also helping to take care of that patient's in a separate and distinct location, and yet you still function as a team with the patient in the center of that team. So I hope that has lent some clarity. Does that help? And I'll put that to the chair.
So follow up first.
Follow up,
Senator
Senator Muhammad.
So for example, under the bill, can a nurse practitioner perform surgeries now? Because again, the bill says any medical act. That's what I'm concerned about.
Senator Bergen.
And Senator Adcock, you correct me if I'm wrong, but they have a scope of practice. Doctors technically have a scope of practice. I don't think that Dr. Reeder could do heart surgery. I don't think he could do.
Not if you want to live.
I don't think he could do brain surgery. But he's a doctor. He has the word doctor in front of his name. But he's still in a level of training, and I would say that's his scope. So when we talk about supervision, I would say that he self-supervises, because he correct me if I'm wrong on any of this, but he works for a system. He knows his lane that he stays in. And I think that's where most of this happens, is there is some self-governing, but also there's the risk of losing your license or your designation and liability. So I think all of those are a deterrent to getting outside of your expertise.
Follow up.
Just a final comment, Mr. Chair, and I appreciate your comments, Senator Bergen. Again, I just fear that maybe your language needs to be tightened up in case people are changing their scope of practice. And I don't know if that language is clearly defined in the bill right now, at least the way I read it, just to ensure patient safety. Thank you.
Senator Adcock, you are recognized.
Your friend's phoning back. So I also just want to point out that term medical acts is an unfortunate carryover from the mid-'70s. That's actually the verbiage that's in the current statute. And so while it's called medical acts, actually what nurse practitioners are doing is advanced practice nursing. So just as Senator Bergen used the excellent example of how Representative Reeder is not prepared to do heart surgery, and neither would he attempt that. I'm not prepared to do heart surgery, and neither would I attempt that. We all know where the edges of our scope is, and if we exceed those, that's why we have regulatory boards to rein us in, discipline us as necessary, because patient safety is at the heart of everything that we do.
Senator Robinson, you're recognized.
Thank you, Mr. Chair. I think my mic keeps going on and off, and you don't know that. I had a couple of questions. Thank you so much. And Senator Bergen, you know that I'm concerned as well, and have always been, about the cost of medical care to individuals, because that's a serious issue for a lot of the folk I serve. But a couple of things that Senator Woodard brought up, I'm concerned about as well, in terms of the supervision of anesthesiologists of just one, which may limit the number of surgeries. And, we dealt with that during COVID. We dealt with a lot of that. So I think we've got to continue to talk about that. And then as we go on into the discussion by Senator Muhammad, I need to get my pun in to say that had we not delayed Medicaid expansion, we wouldn't have lost some of the rural hospitals. So we wouldn't have to be concerned now about how we're going to take care of people, because we don't have the rural hospitals. So we need to increase the scope of practice for nurse practitioners. Now, my great goddaughter's a nurse practitioner, so I'm all for them, but she's in the Army. Army is a little bit different, in terms of what they do. But I am concerned that even for PA, I believe the hours of training are more than for a nurse practitioner. You're saying, okay, Dr. Reeder, thank you for confirming that. So if we're going to extend this to make the nurse practitioner practice commensurate with the PA, then also we ought to be looking at the hours of training that are required. We want to make sure that people have safe care in the area. So I'm concerned about that area. And then finally, the last thing is on facility costs. And I know that increases the cost of the patient, but also in our area, just like Duke and others, our healthcare system has clinics in the community because everybody can't get directly to the hospital depending on where they are. And so they do have to bill and are allowed to bill under CMS for those facility fees. So I think you need to have more discussion with those medical society and those individuals in terms of what is reasonable. We don't want a huge burden on people, but we want to be reasonable in terms of supporting the payment to the other staff that have to do these services.
Senator
Chair,
Bergen.
and yes, ma'am, be happy to discuss that at length. And let me talk just a minute about COVID, because you brought it up. During COVID, there were a number of regulations that were relaxed. Now, to my knowledge, there has not been any incident that happened during COVID where the scope and some of the other supervision was relaxed that generated a issue or a lawsuit. If there is, I've asked a number of entities and I have been told no. So we had a period there of a couple of years where we relaxed things and nothing bad happened. Now, does that mean it would be that way forever? Not necessarily, but I think it is an indication. A lot of things change. We learned how to do a lot of things different during COVID. I dare say very few of us had done Zoom or WebEx or all of these things. I mean, I got tired of it. I think all of you got tired of it because that's all we were doing. But we saw that relaxing some of the regulations didn't lead to the disastrous outcomes that some people thought there would. But happy to discuss all of those things with you.
Okay. Thank you, Mr. Chair. I just want to say, Senator Bergen, now you know that learning to do Zoom isn't the same as caring for a patient. Thank you,
Mr. Chairman.
Mr. Chair.
Senator Bergen.
But a lot of care now is being done over the phone and by video conference. Yes, ma'am.
Thank you. I'd like to recognize my co-chair, Senator Krovic.
Thank you, Mr. Chairman, and this is more a comment than a question. Thank you, Senator Bergen, for bringing this up, and thank you for all the discussions that we've had. And I just want to say, I want to follow up, first of all, with something Senator Mohammed said. Senator Mohammed, my understanding, this is doesn't have anything to do with scope of practice. Nurse practitioners, the advanced APRNs, will only be doing what they do now. They just will not have to be supervised. And supervision is really I don't know what it is, because I've talked with nurses who have never met their supervisor. Never met him. She talks to him on the phone once in a while, but not very often. I talked to one APRN whose supervising physician lives in Tennessee. He's licensed in North Carolina, but he's retired and moves there. He supervises several, and he flies in every 6 months and signs her documents. She says she almost has never called him. That's not supervision. So it definitely needs to be adjusted somehow. This may not be the vehicle. We may make a lot of changes. I'm sure we probably will. But supervision needs to be supervision. I've talked to CRNAs who say the anesthesiologist was not present in the facility where they were working. That's not supervision. And if you're going to be supervising an APRN or an advanced practice healthcare provider, you need to be supervising. You don't. The couple of examples that I told you, they're paying $25,000 to $30,000 a year, and some are more than that. But those two that I talked with, that's what they're paying, and they're not being supervised. That's just wrong. That's just wrong. And I think 30 or 32 other states have already passed some of these issues that we're talking about right now, and safety has not been an issue anywhere. So the fallacy that we're going to make patients unsafe just is not accurate, according to the data that's out there. So I just want to commend Senator Bergen for bringing this forward, and I appreciate it very much. Thank you.
Thanks, Senator Crowley. Any other senators? Senator Mayfield.
Thank you. No comment particularly about this bill, but since the hospital that serves our region has come up a couple of times in conversation, and the cost of healthcare, I just want to point out that for me, what that gets to is the impact of the corporatization of healthcare on cost, and as well as patient care. And I've talked to some of the chairs about perhaps holding some sort of hearing or joint hearing about that particular issue while we're here this session, and hope we can keep those conversations going.
Does any other committee member have a comment? Senator Hayes? Sorry, Senator Johnson.
Our Sergeant at Arms, our fine Sergeant at Arms, like to put me in the middle, and I figured I'd save Senator Mayfield from me climbing over her. So,
thank you, Senator
being
Johnson.
Senator Heights wouldn't be a bad thing since it's appropriations times. But just a couple of comments and maybe a question in here for the bill sponsor. And Senator Bergen, I have great respect for him. I know he always does his homework and does a fine job, even if sometimes we don't agree on stuff. But from the way I understand it, the standard is 4-to-1, and that's the Medicare standard. And also, and that's one of the biggest concerns I have is on the supervision piece. With 4-to-1 being the standard, and I think 45 states have supervision in place today, 1-to-1 seems like we would be far outside of what is kind of the standard and the norm. And typically in North Carolina, we like to see other states. We're very rarely are we the first to step out and make drastic changes. And I would think that to be drastic. And I find myself in kind of a precarious situation with some of the folks that I'm agreeing with some of their comments in this committee today. And I guess we're just going to make this a comment and say that I trust that we'll continue to have conversations. You've always been open to that, and I hope we can continue to have some conversations around that, because I do have concerns regarding the 1-to-1 status and also access to care, as Senator Woodard brought up and Senator Robinson.
Mr. Chair.
Thanks, Senator Johnson. Senator Bergen.
Thank you, Mr. Chair. Senator Johnson, you're in the same business, one of the same businesses I am. There's a thing called compare and contrast, and that's what I'm trying to do here is compare something with something else to show maybe a problem that exists. So thank you for pointing that out very well.
Senator Perry, you're recognized.
Thank you, Mr. Chairman. I have a question for bill sponsor. Senator Bergen, you led off by saying that you want to have discussion and you're putting us for conversation, and I appreciate that. I just wanted to acknowledge that your effort on it. And I agree, while I may have different views or opinions on different subjects at times, you are always willing to have conversations. So I just wanted to echo my colleague and thank you for that. We've had a lot of surgeries in our family over the last few years, so I'd like to talk about prior authorization while we're in here, but that's not the topic. But a legitimate question on the 1-to-1 supervision. I was curious about your thoughts on, so what's the goal for that? Because same knee-jerk reaction for me. I look at it and think that's got to kill throughput. Even if they are doing 4, which I think is probably rare, that's a 75% reduction. If it's really only 2, we're still cutting it in half. So what are your thoughts on that? What's the goal of that? Because just knee jerk looking at him like, man, that's going to be less, right? Less care. So what are your thoughts, if you don't mind sharing? Thank you.
Senator Bergen.
Thank you, Mr. Chairman. It doesn't need to be one. Like I said, I'm trying to show the fallacy of some of these things that have happened in healthcare. And you know, a CMS law says that they can bill for 4 simultaneous surgeries. I can't get a number on how many times that happens, but I have been told that it happens. And supposedly, an anesthesiologist is supposed to be present at the beginning and the end. But I know that that's not happening because I've had people tell me that's not happening. And it's really a problem in rural North Carolina because a lot of anesthesiologists don't want to practice in some of the rural North Carolina areas.
Follow up, Senator Perry.
Thank you, Mr. Chairman. And I agree on that. Difficulty in rural areas, no matter what we do, any topic, forget healthcare, right? Getting folks to want to live in some of the areas out, the amenities has proven to be a challenge over time. For clarification on an anesthesiologist having to be there, my understanding is that there's 2 different. One is for billing purposes, right? There's a guideline on what an anesthesiologist has to do, but for supervision purposes, isn't it just a medical doctor, not an anesthesiologist that has to be present?
Mr. Chairman Bergen, my understanding is it depends on the practice. I talked to a gastro guy about this. He has and I talked to Dr. Reeder about this. He has a nurse anesthetist that works for him. He supervises her, but they're not doing the deep dive that major surgery. Doctor, correct me if I'm wrong on this. They don't do the deep anesthesiology, the serious surgery, heart surgery, brain surgery, all of that. They're more of a lower level where you can do it. And I understand those are not as complicated, so they do that. Now, could he supervise on heart surgery as a medical doctor? My understanding is no. And he even told me when I was talking to him, he said, Jim, and I've known this guy for years, we're good friends, and he's a client. He said, if something happened during a surgery with anesthesia, he said, it's been so long since I've had that training, we call 911 and keep somebody alive till they get here. So, there are different levels. And I'm glad this is the most we talked about this since I've been up here. And I'm glad we are. And I want the anesthesiologist to come and talk to us passionately about it and tell us a better way. But if people can't get care anywhere in North Carolina, to me, that's a real problem. I mean, we're 100 counties and the majority of them are rural. And look, I've got 2 hospitals in Harnett County. They're now part of Harnett Health. Did you know we have no maternity in Harnett County now? There were 435 babies born in Harnett County in the last year period. Today, I was talking to Rex this morning. Guess where they're all coming? Rex and Wake. They said they've seen a huge increase in maternity because we've closed that. Now we're trying to get it back open. I've been meeting with them, and trying to get to OBGYNs because you got to have at least 2 so they can cover each other. But think about that. 435 women have to leave Harnett County, drive a minimum of 38 to 40 minutes on a good day. I mean, I can leave my house sometimes. I can be here in 38 minutes. Day before yesterday, I think it was an hour and a half to get here because there was a wreck in Garner. So that's what this discussion needs to be, a lot of things. And I'd love to talk about prior authorization and pre-admission certification too.
Follow up, Senator.
Thank you. Lastly, just a comment about the rural areas. I don't want to be too negative about the rural areas. We do have a Starbucks in Kinston, North Carolina now, so we're open for business. If anybody wants to move there, you're welcome. We could even open a new restaurant soon, so who knows? Thank you.
We now have
Good point.
We have 2 Starbucks in Franklin, believe it or not.
I knew it.
Any other comment from Senator Batch?
Thank you. They're still waiting for the Wegmans and the Aldis, though, so y'all can just wait on that. So I really appreciate you, Senator Bergen. You're always a great person to work with and really thoughtful with regards to where we are in this discussion. I would just like to emphasize a couple of points, pointing out what Senator Perry had mentioned before, is that I'm very concerned about the 1-to-1 ratio, and it seems like you're very open to that changing. My concern is trying to make sure that we are going to allow for surgeries to continue. I have spoken with many women who have had to go through cancer treatment and surgeries that they've had to wait weeks and weeks. And so if someone's been diagnosed with, obviously, cancer and they have to wait a very long time, also would like to talk about pre-authorization too, it is really, really distressing for them. And someone who has had sadly 7 surgeries, I very much and have complex issues with regards to anesthesia. I need an anesthesiologist to actually be present in the room with me, all right, and directly there. So as we move forward, I hope that we can not only talk about that and what's going to be best practices and how to get people to rural North Carolina. My concern is this passed, rural North Carolina would actually have less access because of what we've talked about today. And then the only other thing that I will say is that I think we should have a very serious conversation about education and how much experience individuals need to have prior to being able to just practice. And I give the example all the time of therapists. Most therapists have to have 3,000 hours of supervision by a licensed clinician. And I think we can all agree that you don't want to decrease that because you're talking about the mental health needs of a person who's extremely vulnerable. I don't see it any different with regards to the medical area, and we should just be really thoughtful to go ahead and in these conversations figure out a way for us to expand access to health care while still meeting the needs of the patients. My last and closing point from the my insurance colleagues in the room. My other concern is obviously patient safety and care. If we are going to look at scope of practice at some point, I am concerned that the patient needs to have the same access to malpractice coverage of whomever is the person who's going to be dealing with that. And if they don't have the same scope as the highest level of most surgeons or doctors who are sued, we really need to consider making sure that that patient, if they are harmed by whatever level practitioner it is, we make sure that they have the same malpractice coverage and insurance that the physician would have. Thank you.
Thank you, Senator Batch. Senator Adcock.
Thank you, Mr. Chair. And I just want to echo what Senator Bergen said. Any day that we have this much time to talk about how to increase access to care and by fully utilizing our nurse practitioner and other APRNs and PA workforce is a good day. So I'm really welcome the conversation. And I always appreciate Senator Bergen and everything he's done over the years since he's been here about trying to increase access to high quality care and good patient outcomes. So I want to say that in public. That said, I do think, as you've acknowledged, that this kind of bill needs lots more input, lots more conversation, and I would be remiss if I didn't point out some inaccuracies that have been stated during the conversation, and I wouldn't want anybody to leave today and not know the real number, so I'll point this out. 40 states do not require supervision of CRNAs, so they're not held to this 4-to-1 ratio. That's important, I think, to know. And also 27 states, 2 territories, and the District of Columbia have passed legislation similar to the SAVE Act and using nurse practitioners and other APRNs within their full scope of current legal scope of practice through education, certification, experience as long ago as 30 years. And in those states, nurses aren't performing, open heart surgery or things like that. Their liability insurance claims and cases have not risen. There are at least 3 decades of research about the safety of APRNs in particular, the high quality of care, and the excellent outcomes they give. So I just felt that was really important for people to walk away knowing. But I welcome this conversation. I look forward to working with you, Senator Bergen, and others as we all work together to try to get to the same goal, which is giving people access to great care in our state. So thanks very much.
Thanks, Senator Adcock. Any other senator have a question or comment at this time? If not, I know Sergeant Arms, did you have anyone else sign up, or you have one name?
Mr. Chairman.
If you have others, if you get those to me.
Mr. Chairman.
Senator Bergen.
Let me make one comment.
Yes, sir.
Ladies and gentlemen, we've got, I don't know how many PAs here today, a lot of PAs. And anybody you see in a white coat, I want you to do something. I want you to go up and thank them for being a PA. I want you to thank them for being here today. Tell them you appreciate them. Hug them if they're huggable, and but pray for them too. They've got very difficult jobs, And we need more PAs out there too. So guys, thank you all for coming today.
Mr. Chairman, I would point out the institution that is the birthplace of PAs.
Representative Baker, did you?
Wrong school.
Sorry. No, please stay. Thank you, Senator. Thank you, Mr. Chair. Thank you, committee. And thank you so much, Senator Bergen. I want to echo the comments that we all care about patient safety. I know, Senator Bergen, you and I have had a lot of conversations, especially mental health care and medical care as well. And so I think, access, safety, cost, all of those things, prior authorization, so important to talk about. And so my only reason for speaking now is that I want to make sure, I'm thankful we're going to have conversations going forward. But in those conversations, I just wanted to make sure when we're talking, whether it's 4-to-1, 1-to-1, whatever we're talking about in terms of anesthesia oversight, I want to be clear that in those discussions, we're aware of the actual reality of what that supervision must be. So according to the billing standards and the rules, the anesthesiologist must do a physical exam. So the anesthesiologist must perform a physical exam in advance of the procedure. The anesthesiologist must prescribe the entire plan for the surgical anesthesia. The anesthesiologist must be present for induction and emergence and any other major events. And the anesthesiologist must personally document all of that and be on site. So if this is not happening, we need to go after it. We want to know those cases. The medical board wants to know those cases. And so I know we are, Dr. Reeder and I are very excited about looking at supervision, because if any of our clinicians, and especially our doctors that we represent, if they're not doing the right thing, they need to be doing the right thing. And this lack of supervision is intolerable. So I fully agree with that. I just want to be clear that when those discussions occur about how many patients to a given anesthesiologist, that the understanding is they must examine the patient, they must prescribe the entire treatment regimen, they must induce and emerge, and they must write those notes themselves. So so when you talk about that, 1-to-1, 1-to-4, please know that that's the reality of the actual interchange.
Yes,
Thank you, and I appreciate it.
Yes, ma'am.
Thank you, Representative Baker. I have one person that signed up from the public. If others want to speak, you'll need to let us know that. But Ashley Rodriguez, I think, is Ashley here? Should not. Okay. Does anyone else from the audience wish to speak to this bill? Senator Bergen?
Thank you, Mr. Chair. That's all.
Seeing no one, let me go back to my comments at the beginning of the meeting. We made the decision to make this discussion only for the reason that a lot of senators have said today. We need to talk about this. This is very complicated issues, and there are several issues within this bill. This is not one single issue that we're dealing with. So those conversations are going to happen between us before we come back, and we anticipate having this bill back perhaps next week to review again. So anyone else? If there's nothing, then this meeting will stand adjourned.